has disabilities, or whether they have a migrant status, and how that affects their access to COVID-19 tools and pandemic tools more generally. Some examples of how global health agencies responded or used the gender lens in the COVID-19 response, as well as some country responses and examples. And throughout the report, you'll see several case studies of how countries responded and how they employed a gender lens, or whether they did or did not employ a gender lens. So let's get into it. Definitions first. So out of the 15 organizations that participated in our research, 7 defined gender solely in the women and men binary, excluding gender non-conforming or trans individuals. Of the others that had a wider definition of gender, they were mostly civil society organizations. So it's quite clear to us that some work needs to be done to expand gender beyond just women and men. So why do we use the wider definition of gender? And of course, focus on women and girls is absolutely warranted, and there are particular issues and concerns related to women and girls' access that are important and have to be dealt with. But we also know COVID had a tremendous impact on all marginalized people across the gender spectrum, including in gender-based violence, economic power, and access to sexual and reproductive health services. So we took this wide definition of gender because we also know that these are built by the same systems of patriarchy that create gender discrimination and keep women and gender non-conforming people in poverty. So this wider definition is really designed to create a more equitable, gender-sensitive response to pandemics that is inclusive and addresses all the factors for access as regards marginalization. So let's go a little bit into the gender-related structural barriers that we mentioned in the report. So first of all, we've got gendered social norms and traditional roles. And overwhelmingly, we focused on how women were predominantly, had the predominant role of being the child minders and reared children and cared for children. And that affected access to COVID tools in a number of ways, including the fact that many did not have the time simply to go to large hospitals to get their COVID vaccines, and were mostly stuck in the home because they didn't have access to the main transportation method. If the family owned a vehicle, it was usually owned by the male, and the woman often didn't have access to the transportation. So there were those factors, and then health systems factors, including digitization of COVID tools. So in Malaysia, for example, registration for vaccinations and tests and other services occurred through the MySejahtera application. And in many countries we looked at, there was a lower level of women who had access to smartphones compared to men, and this impacted their access to those COVID tools. We talk a little bit more about right to information, digital divide, and community engagement and communication strategies. And the example, the extreme example that we cited here was a case in Afghanistan where the quote comes from. So there you've got a quote from an expert that we interviewed anonymously because of sensitivities around the Taliban, where less than 35% of women said they have access to digital skills or radio or TV, or even access to phones. But most of the messaging that happened through WHO, UNICEF, and the rest was through massive awareness campaigns on digital platforms and radio, TV, and SMS. So many women within the Afghanistan context were left behind. And now we have a specific case study on what happened in Afghanistan in the report if you're interested. But essentially, women were accessing services, all sorts of services at safe spaces and other areas where they were allowed to bring their children and congregate without a male partner. So ideally, that would have been taken into account when considering community engagement and COVID. And of course, we look at unpaid labor and compromised income generation during the pandemic. And on unpaid labor, it was an important consideration just because a lot of global health agencies and governments in their messaging on COVID didn't consider that that they were heavily impacted and usually are carers for sick family members, and therefore have an increased risk of contracting COVID. Next is intersectional identities. So we looked into the situation where you have a woman who might not have access to transport and might be responsible for taking care of children, who is also disabled or also a migrant and maybe locked out of government provided vaccination and testing services. And as you can see, this quote from Vanita Mukherjee from Dawn in India, you need a very sensitive government to understand these problems in their various dimensions, and only then can you create solutions and universal access is possible. The next quote is from Dr. Sagri Singh, who I believe is on this call, and we thought it was an important quote to highlight that if someone's less educated, if they're from a lower ethnic group or a minority group or a particular caste that is considered to be lower, you automatically start going down the chain. And at every point, if you're a woman with all these factors, you're probably at the bottom of the chain. And if you're a trans woman, you're further at the bottom. And therefore, you need a decolonial feminist approach that speaks to tapping experiences and valuing experiences as much as academic research, which doesn't always capture the nuance. And this really translated into our recommendations on why a gender lens at the outset of pandemics is incredibly important, because if you don't look into all these factors, you are going to miss having these people access important services. Now, what did global health agencies and gender do? Because it's quite a long report. We cover 4 global health agencies in the report, but I'm covering 2 today in this presentation. The first organization we looked at was Gavi. Now, as many of you probably know, there was a checklist developed and which was sent to COVAX-supported and self-financing countries, as well as COVID-19 vaccine deployment coordinating committees and national immunization program managers. However, there was some dissatisfaction that that was the only action that this checklist was sent through, but there was kind of no follow-up, or there was no requirement that they need to fill it up and complete it before they deployed the vaccines. And we have one stakeholder who we interviewed in the report who said COVAX could have said this, could have made a requirement for countries to fill it up before they got their vaccines. What we did was we asked Gavi to respond to this concern, and that quote is also in the report. And Gavi said they apply a robust gender policy across all its programs, and said that requiring countries to fill in the checklist before they got their vaccines was not a precondition because of their emphasis on a rapid, streamlined process. So in our analysis of this, we wonder whether this is the right approach to things. If you have a checklist, but you use the pandemic as an excuse to not make it a requirement, when you know that during a pandemic, gender-related barriers are disproportionate and amplified, what kind of message are we sending? And essentially, that's how we interpreted that. This was observed in other global health agencies as well. So with the World Bank, and the World Bank has really an amazing practice that we don't really see in other global health agencies, which is gender tagging. So every project that the World Bank does requires a gender gap analysis and indicators to address the gap that was identified during the gender analysis. So what happened during the pandemic was they adopted cheat sheets instead. They didn't have an official name for it, but they did call it cheat sheets. Now, the cheat sheets were really quite comprehensive, and in Figure 7 from the report, you can see several things that the cheat sheet contains. I did have a critique from someone that says this isn't enough. There's more. The real cheat sheets have a lot of things, but there's only so much you can fit in a little orange rectangle. So those are selected items that are in the World Bank cheat sheets, including training healthcare staff to identify GBV cases, appropriately handle disclosures, consider paying people for the provision of unpaid care, include equitable representation of women and men in emergency management groups, consider female healthcare workers' specific needs. Yes, PPE need to be tailored to male and female sizes, and include consideration of childcare for women essential staff. As you can see, this is a women and men binary and doesn't include gender non-conforming individuals and trans people. But regardless of that, it is quite a comprehensive cheat sheet. But it is simply a guidance, and their comprehensive gender gap analysis wasn't deployed because of the need for agility. However, one thing that we questioned was whether a kind of smaller gender gap analysis, maybe through 3 focus group discussions or something, could have still been done as part of the requirement to access World Bank funding. But either way, and throughout the 4 organizations we looked at, there were a tendency to abandon a gender lens or to establish gender-related procedures because of the need for agility. And it will be important to look at this in the inter-pandemic phase to make sure that we have contingencies that are better than what was prepared for future pandemics. The next part talks about some country responses, and in Malaysia, we looked at how trans people were accessing testing and vaccination services. Malaysia doesn't have gender legal recognition, so trans people are still listed with their birth genders, complicating access to health services generally, because when they show up at health services or vaccination center, they're often, either abused or refused services, or essentially there is a barrier to accessing services because of the fear of bullying. In addition to that, at many vaccination centers, there was police presence to maintain order and crowds. And because police are involved in the arrest of trans people for cross-dressing, that's the official terminology in the Malaysian Sharia law, which states that cross-dressing is a crime. So the fact that police presence at vaccination centers wasn't taken into account was something that was concerning and reduced access of trans people to vaccinations. So we spoke to a local organization that works on access to healthcare for trans people. And what happened was, and this was an innovative approach, given the legal environment, a government-linked NGO contacted the NGO focused on trans issues to collaborate and work together on vaccinating those who are marginalized or socially excluded. So they obviously knew that this was an organization that worked on trans rights, but they were trying to work around the rigid laws to make sure that trans people were able to access vaccines, and they worked together, and they were able to recruit more than 3,000 trans people for vaccinations. So this is a good example of how folks work in an operationally difficult environment to make sure that gender non-conforming people and trans people are able to access vaccines. In Zimbabwe, where there's quite a lot of stigma and there's been historic demonization of the LGBTQIA population, initially the government really didn't take into account the need for safe vaccination spaces until GALS, which stands for Gays and Lesbians of Zimbabwe, were approached to potentially have safe vaccination spaces in their own facilities, and this happened after a lot of advocacy and engagement by the LGBTQIA community, who said that the government had left them out. And what they did was they did have vaccinations in LGBTQ support centers and the GALS facility, which increased access greatly. Now, country responses. There's a really brilliant example of how South Sudan worked on addressing the challenges. So what happened in South Sudan was they rolled out vaccines in large hospitals only in the start. And it was only after a couple of months of rolling this out that they realized that 75% of people accessing vaccinations were male. And they needed to understand why this was. So they did social listening exercises. And you can see that UNICEF officers in many countries did social listening exercises, and it should be considered a best practice in future pandemics as well. And what they realized, obviously, but when you have vaccination centers and testing services only in large hospitals, is that women don't access it. And in South Sudan especially, there is a situation where women still have to ask permission from their male partners to access healthcare in general. So there was a barrier for women to access services. So there was a multi-pronged approach here. They set up vaccination sites at churches and markets where women predominantly were during the daytime. And when they were there, they didn't have to ask permission from their husbands because their husbands weren't there. So they could bypass the permission element, and they could sign their own consent forms and get vaccinated there. UNICEF South Sudan and the government of South Sudan also conducted advocacy towards men in the patriarchal communities to act as supporters of women who wanted to get vaccinated. They did interactive radio sessions with vaccinated female panelists. They did engagement and advocacy with female influencers. Now, distrust of the health system was quite a big factor in South Sudan, so they tended to use female influencers, religious leaders, community health workers, and political leaders, as well as do radio programs at the village level and community dialogue. So it was multi-pronged approach and a highly successful approach that resulted in a lot more vaccinations among women in South Sudan. And I would really encourage, if you only have time to read one case study in the entire report, I would recommend South Sudan, just because it was highly successful and best practice for future. But of course, if gender had been factored in from the very beginning, they wouldn't have had the initial problems with most vaccinations being taken up by men only. And of course, this is more on South Sudan, where there was a lot of advocacy done and women signing their own consent forms. And you can see there by November 2022, the proportion of women vaccinated in South Sudan reached 51.5% of the total cumulative vaccinations. So from the report, we created several recommendations to governments, and this is just a portion of the recommendations. They're quite long, and that includes to publicly report sex and gender disaggregated data on pandemics, but to also include age, race, ethnicity, migration status, disability. And I know that this is a long road, because countries aren't frequently enough or well enough reporting sex and gender disaggregated data, but we recommended the ideal that they should also record other things such as migration status and disability. But of course, this can result in problems in countries which are authoritarian. So this needs to be considered as well. We also emphasize the need to recognize and decriminalize the existence of gender diverse people, and have some recommendations for global health agencies that ensure commitments to gender sensitive programming remain during crisis and pandemic periods. The report finds that, of course, as mentioned before, a lot of agencies suspended their gender sensitive programming or gender tagging or other checklists and things like that. We think that the COVID-19 gender checklist should be adapted for future pandemics and be used as a prerequisite and not just sent to countries, and to expand definitions beyond a binary view of gender. So we've got several other recommendations in there. So please do read the report, and we welcome feedback and your thoughts on it as well. So many thanks from Matahari Global and our all of our colleagues. Thanks very much, and happy to get questions and thoughts.
Thank you so much. If folks on the line have questions on this report for Dr. Rahman, please raise your hand and I'm happy to let you come in, or you can also type some questions into the chat. I'll start off with a first question. And you had alluded to this earlier in your presentation that, sometimes in times of crisis or emergency, governments or agencies can say, in order to move quickly, we don't have time to take gender considerations into account or other things like that. So I would be curious what your answer is to that, in seeing that when you don't apply a gender lens from the outset, there's negative implications. So where do we go in terms of challenging that narrative?
I think so. We have quite a strong opinion on that, and we think that a lot of these were so sending through documents and saying that you've done your job on gender, knowing that it's gender-related barriers are amplified, is a bit of an excuse and a poor show. So I wanted to come back to this cheat sheet, right? So you can always select 2 or 3 things from this list and ask. You don't have to do the whole thing. There's obviously lots of things in this, but to ensure that the 2 or 3 most important things are handled or answered as a prerequisite by the government before you deploy funding, it's going to take 10 minutes or most an hour for the government department to fill up. So we thought it was a little bit of a derogation of what organizations had committed to. So I think we need to engage in serious conversations about, look, we know your guidance is established, and you've got really good stuff in your checklists and in your cheat lists and whatever people are calling them. But realistically, in the next pandemic, which we know is coming within the next 25 years, you know, what 2 or 3 things can you make as a prerequisite for governments to fill out before they access your funding or before they access vaccines? And I think that that's where the conversation needs to go.
Thank you. And that is one thing we've been discussing as part of this working group, especially around the gender and other stratifiers for disaggregation of data and how we could help promote that as a requirement in the pandemic accord, for example. So it was great to see that come up as a key recommendation from your report findings as well, because that's certainly a first step, is just sort of understanding what the impacts of different policies and services are on different individuals and all of their intersecting identities. I see a question in the chat that's asking you to touch on some of the implications of access to vaccines related to hoarding and abilities of different continents and countries to access and manufacture vaccines. Did you see any gender ties to that in your research?
So the only thing we saw on that was how scarcity as a result of hoarding resulted in distrust, and this distrust was more difficult to address among women because of the digital divide and where they accessed information in many LMICs. So you've got the hoarding and people going to get their vaccine and then being asked to return at a later date on a specific date. And when they get there, the vaccine's not there, and they've already spent their own money, which they don't have much of because it usually comes from a male partner, to travel to the center to get the second vaccination. So it results in distrust. And they didn't have, a lot of people didn't have appropriate communication and respectful communication approaches from governments or global health agencies on why this was happening. So when misinformation started to spread, women didn't really have anywhere they could address those concerns. So, and yeah, it really was kind of domino effect of scarcity, not being informed that the vaccine wasn't there, so and they had spent their own money to get to the center, and really had a domino effect and impact on mistrust and misinformation.
And then just one more question from me. As this group comes together to think about how we can collectively advocate for gender responsive policies and practices, especially as a lot of policy debates are happening in the global space, including around IHR reforms and a new pandemic accord, what would be your biggest recommendations to this group for how we can collectively show up to make sure that policies that are under formation right now are more gender responsive than they have been?
Yeah, it's a tough one because when I was on the medical countermeasures platform working group, one of the things that we kept pushing was the need for a gender resource group that is present in all working groups on future medical countermeasures platforms, for example. And this includes that these experts would be in the R&D working group, it would be in the access working group, it would be on the intellectual property working group, because it shouldn't just be a tiny group of us talking among ourselves, and it needs to be integrated in all others. But I sense there's still quite a limited understanding of how gender impacts all of these things, and our male colleagues aren't necessarily super invested in it either, even though it impacts them, and they're key actors in supporting women and gender diverse people in accessing these services. So I do think there needs to be more pushing to have gender experts in every working group, rather than having a siloization of a gender expert group. And I think that's what we think should happen at the first instance.
Thank you. That's a very helpful suggestion for making sure that gender expertise is mainstreamed and integrated throughout all negotiations, not just in a separate gender working group. Vera, I see your hand up. Please feel free to unmute and ask your question.
Yes, I unmuted. Thank you so much. Courtney, you kind of touched on the point that I was going to make. Thank you so much, FIFA, for that wonderful presentation and the report. I'm from the World Health Emergency Program, WHO, and I'm the coordinator for the Gender Working Group. It just so happens that the World Health Emergency Program has been looking very much towards gender in the next pandemic, of course, from lessons learned in COVID-19. And the question I was going to ask was a bit of what Courtney touched on and which has been answered, how you see the value of partnerships and the relevance of making sure that workforces are balanced, that we have women especially and people from other groups who understand what the differential impacts on emergencies, especially on women and girls and on different groups of people. But I think you've answered the question, because we have a strategy in place, and outcome 2 and 3 of the strategy. Outcome 2 is to make sure that we have a gender balanced workforce when it comes to dealing with pandemics. And outcome 3 is accountability, partnerships, and advocacy. And I just want to say that we launched an online course, Taking Sex into Consideration in Communicable Diseases, and it's online. I can share the link with everyone. It's quite interesting because we have it's quite a robust and interesting course, and we are sharing it with partners and hoping for their input and comments. But it has, the main point is that it uses uses a gender analysis matrix in dealing with infectious diseases. Thank you very much.
Thanks so much, Vera. I think you're more of an expert on that than I am. But I certainly agree with you on the need for the need to be a gender focus in workforce, and really pleased to hear about the outcomes that are in your work, and I'd be interested to know more. But certainly in partnerships, I really think that's the key, right? Because there are organizations like there's so much expertise in UNICEF, and of course we interviewed WHO for this report as well, Shirin Haydari and Tracy as well for this report, and there's certainly a lot of expertise within WHO, but some organizations just aren't looking at it, and or they're looking at it at a superficial level, and the fact that organizations are suspending their gender works during a pandemic, not ideal, not the right way to go. So I do think there needs to be more discussions on it, and to have more of the male global health leaders in the room, because I think there's a lack of understanding on access. And whenever we talk about access to COVID-19 tools or pandemic countermeasures, it is predominantly a conversation about tech transfer, about R&D funding, about intellectual property and supply and hoarding, but the gender factor isn't in there, and I think we need to mention it clearly. In fact, we just completed a survey for the incoming Italian G7 presidency, and so few people mentioned gender as an access problem. And me as a consultant who also worked on this project for PVA, I can't manipulate the results, obviously, but I was disappointed to see that only very few people mentioned gender as a barrier to accessing pandemic tools. And I do think that partnership's extremely necessary to address it.
Thank you.
Yeah, thank you. That's a really important takeaway for us, especially so that we can collectively raise gender itself as a barrier to access of COVID tools and technologies. It's surprising to me that that wasn't a strong report finding either. Thank you, Dr. Rahman, for sharing this report with us. We will share this recording, and links to the report have been shared in the chat, and we will share them again. I'm happy to transition to the next presentation for our agenda today. Mahmood from Women in Global Health, the floor is yours. And if you have slides to share, you have that ability.
Thank you so much, Courtney, and hello, everyone. Give me 1 minute just to share my screen very quickly. All right, I hope you can see my screen. Amazing. Hello, everyone. My name is Mahmoud. I'm a new policy associate at Women in Global Health, coming in for Becca, who most of you might know and who have been part of the working group in the past months. I will be presenting today a recent policy brief that was developed by Women in Global Health on gender-responsive pandemic preparedness, prevention, response, and recovery. This policy brief was developed with the support of a grant from the International Development Research Center, IDRC. And in it, we try to capture and reflect on the essential elements needed to advance a gender-responsive health system and health security, and to advance gender equity in pandemic preparedness, prevention, response, and recovery. We launched it about 3 weeks ago, ahead of the 7th meeting of the IMB, and ahead, of course, of the negotiations of the pandemic agreement. Now, setting the ground. Women constitute the majority of the workforce, of the health and care workforce, over 70% of health workers, over 80% of nursing and midwifery roles, yet occupy 25% of leadership roles, and even their presence on policy discussions are limited, as we see in the chief delegations of WHA. Women lead the delivery of health and care services, yet women still face huge inequalities in healthcare systems, low pay and pay gaps, inappropriate PPE that are not fit for purpose, the burden of unpaid work, and the lack of support for mental health and social care. Now, during the COVID pandemic, women have been the majority of the frontline workers delivering patient care in the pandemic. They were the shock absorbers of the pandemic. In the policy brief, we try to provide the perspective on the gendered impacts of COVID-19. We saw that women and girls have borne the secondary impacts of a pandemic, which for many of them has weakened their social and economic positions that have been already in a weak state before the pandemic. There was a significant increase in gender-based violence and the double burden of care placed on working women. Women faced unsafe working conditions, the ill-fitted PPE. They were marginalized in leadership and decision-making regarding the pandemic and the response to the pandemic. Essential health services were disrupted. This includes, of course, sexual and reproductive health. It includes maternal and child health services, which led to increase in maternal mortality and, of course, unsafe abortions, among other health challenges. the multiple stresses that the pandemic have created and has impacted women health workers who were already in a more unequal position in the health workforce, caused widespread exhaustion and burnout to the workforce. In a separate report, these impacts we found that led to a great resignation of women health workers, particularly in high-income countries. We identified there is an exodus of health workers in high-income countries that are leaving the profession and driving a great migration of women from low and middle-income countries to high-income countries to fill these gaps, which escalates the pressure on vulnerable health systems and creates a vicious cycle. In this particular report, we asked the diverse network of the Women in Global Health movement chapters to draw on their lived experiences of the pandemic and to recommend concrete solutions, national level solutions, policies, actions, activities, and programs related to women health workers that the governments should implement to better prepare for and respond to future pandemics, which we hope that we could be utilized as a tool not only in the negotiations for the pandemic agreement, but of course, beyond the pandemic agreement and its implementation towards driving better and stronger health systems. We received feedback from representatives from 37 chapters in 31 countries, comprising health workers, academics, policymakers, non-governmental organizations, government representatives, and students as well. And these have informed the recommendations of this policy brief. These are some of the contributions of the participants that filled the survey. The survey data and the results of our qualitative analysis forms the foundation for the evidence-based recommendations presented in the policy brief. Some of the key themes that emerged were common across countries with diverse socioeconomic statuses and cultural contexts. These key recommendations include 7 major points that the governments must follow in order to prepare for future pandemics and to strengthen the resilience of health systems while ensuring they are gender responsive. Number 1, that is the prioritization of women health workers and their safety. Number 2, investing in capacity building of women healthcare workers to respond to the pandemics. Number 3, ensuring health systems are more gender responsive. Number 4, conducting regular risk assessments of health systems, infrastructure, and the workforce. Number 5, ensuring better working conditions, better benefits, better incentives for women health workers. Number 6, investing in innovation or innovative, collaborative, and gender responsive research. And number 7, and finally, improving the coordination and dissemination of information. Now, as governments and stakeholders prepare for the future pandemics, the voices of frontline health and care workers offer a very invaluable guidance to the development of future policies and future plans to respond to pandemics and to strengthen health systems. The imperative echoes clearly to protect, to empower, and to involve women health workers. This entails safeguarding them from gender-based violence, ensuring a steady and gender-appropriate supply of personal protective equipment, PPE, and providing essential mental health support. In addition, specialized training programs, mentorship, equitable compensation are all of urgent need to empower women health workers for leadership roles in global health and health policy, and of course, meaningful engagement during the times of decision making and policy design are also critical. In this policy brief, we call on governments to prioritize the safety of women health and care workers, to prioritize their empowerment and the equitable treatment or their equitable treatment in their future pandemic preparedness efforts, in their discussions regarding the pandemic agreement, in the implementation of the pandemic agreement after hopefully the member states agree on it, and in any national pandemic preparedness and prevention plans. That was a very, very quick presentation of the policy brief that we have prepared regarding the gender responsive health systems. And I could hand over back to Courtney for any questions, if any.
Thank you. From my perspective, it was really interesting to have these two reports presented together because they both looked at the implications of the COVID-19 pandemic with different populations and organizations working in countries around the world to understand what the real impacts were and suggestions for the future. And I personally found it interesting that many of the issues and points raised in this Women in Global Health report, Mahmood, were part of the suggested gender checklist that was followed on the World Bank gender tagging in the report from People's Vaccine Alliance. So it's great to see the overlaps here. And I'm curious what your perspective might be on what that means in terms of policy recommendations that are specific to take forward. Any perspectives from you or Women in Global Health more broadly?
I think the overlap in terms of the recommendations reaffirms them, really. Reaffirms that these recommendations come from on-ground experience, from lived experience of frontline health workers that have faced these challenges and are reflecting them. These recommendations coming from different perspectives, different organizations, not totally different reports, highlights that there is a critical need to respond to these recommendations. And there is a critical need that these recommendations are reflected in a more practical manner. They shouldn't stay recommendations on paper or as outcomes of reports, because we will still see them in future reports if we continue like that without any concrete implementation plans, without translating these recommendations, operationalizing them in the policy design, in the policy implementation for future pandemics.
Thank you. Are there any other questions for Mahmood? The floor is open. I'll also open the floor for any thoughts and reflections on where we go from here as an advocacy community in terms of advancing these or other recommendations in the policy processes that are underway in the close of this year and ramping up again in 2024, and how we show up collectively. From my perspective, I see a real need to push on gender disaggregated data, and I think that's somewhere where we could really see a win in the debates that are moving. Betty, I see your hand. Please come in.
Yes, good morning, good afternoon. In Uganda, it is good evening. Thank you so much for that policy brief. I think I mentioned it, and I see he has also pointed it out that we need women in these decision-making processes, where women are also part of these decision-making boardrooms, but also budgeting processes where women are part, and it has come out key in equality in decision-making processes. And I think because women are the ones who are actually affected with these pandemics, so there's need for them to be in these boardrooms while they're making decisions for them. Thank you so much.
Thank you, Betty. That's another really important point to take forward, is the inclusion in the policy and decision-making processes, which hasn't always been as straightforward as we would want it to be. Marielle?
Yes. Hi, this is Marielle with CARE. I was wondering about the pandemic fund, and I know there's a second round of proposals coming, will be released by the end of this year. So if we can find ways to see how we can engage with countries that are planning to submit a proposal to the World Bank for funding, if we could find ways to have some kind of dialogue to see if we can get frontline health workers, female frontline health workers, and gender responsive budgeting, get those, potentially included in pandemic fund proposals, because I think there's a lot of opportunity there. In the first round of proposals, a lot of countries have prioritized the health workforce. So yeah, I would be keen to further discuss that once the next round is released for pandemic fund proposals.
Thank you for raising that. That is a strategic opportunity, especially looking into what types of requirements might be needed to make funding proposals. I see from Faith in the chat about asking ourselves how we will measure equity and inclusion. I think that's always challenging in terms of knowing, do we have the right data to measure, but then what levels do we deem adequate? And, for different types of interventions or things we're measuring, different levels make sense, but would welcome other thoughts from people on the line. Well, I know that these reports have given us lots of food for thought as we regroup at the end of 2023 and look ahead for how we can make some collective impact on gender in the pandemic PPR space in 2024. We have lots of opportunities that have been flagged, including through the Pandemic Fund, the INB process, IHR reform, and different policies and reforms that are happening at the national and regional levels. So a thank you from me as part of Pandemic Action Network. I'll extend a thank you from Women in Global Health, but Mahmood, please feel free to come in for engaging with us this year. This has been a really robust network. We've learned a lot, and I think there is a lot of opportunity for us to continue to work together. So thank you very much, and we look forward to an active 2024. Mahmood, any goodbyes from you?
Yes, reaffirming the thank you from Courtney. Thank you everyone for your engagement over the past months. I cannot say much because I'm new to the process, but definitely from the feedback of my colleague Becca, who has engaged in the process, this has been a very engaging process. We look forward to the future of it in 2024. And thank you so much once again, everyone.
Thank you. Have a wonderful rest of 2023, and we look forward to seeing you all in the new year.